Good afternoon, everyone. Center of Excellence in HIV Care School of Tropical Medicine, Kolkata welcomes our speaker and all participants to the Regional Distance Learning Seminar Series. Dr. Nivedita Dutta is our speaker today. She will elaborate her discussion on provision of second and third line ART among adults and adolescents. Dr. Nivedita Datta, MBBS MSc, Clinical Research and Regulatory Affairs, PDCR, is presently working as Senior Medical Officer at Center of Excellence in HIV Care, School of Tropical Medicine, Kolkata. She is actively involved in various HIV-related research projects and has attended conferences and published articles in international journals in the relevant field. I request Dr. Datta to kindly start the session.
Thank you, Renita, for the nice introduction. The topic of discussion today, my topic is provision of second and the third line ART among adults and adolescents. Now, today, basically, second and third line is decided by SASEP, but we all need to know how the regimens are changed, what are the reasons behind a change, when do we change, and how, like, what are the drugs that are chosen, and what are the side effects of those drugs. So the five major aspects I will be talking about today is about ART treatment failure, viral load testing and adherence support, treatment failure to first line and second line ART, second line ART failure and third line, drug-drug interactions with key ARV drugs. Now, what is treatment failure? We all know, as per definition, that is the antiviral efficacy has been lost. Basically, the drugs which were previously active against the HIV virus, that is HIV 1 and 2, they are no longer working in our body, and so it is showing a failure. That is, our blood tests are showing a high viral load. Suspected immunological failure, which is nothing but the unsuppressed viral load along with our clinical indicators, low CD4. These are the immunological failure indicators. And before identifying the treatment failure, certain factors like ART duration, new OI or iris, and treatment adherence must be considered. So when we are defining a patient, classifying a patient as treatment failure, we have to look into these issues like the ART duration. This is very important. New OI or iris, and the treatment adherence. This is also very important. I will be elaborating on these things in my next discussion. Now, coming to the defining treatment failure, how do we define? We all, by this time, we all know about these things. There's the three types of failure we have, usually a virological failure, an immunological failure, and a clinical failure. Now, what is a virological failure? We all know that we are sending the samples for a viral load test to our referral labs. And when the viral load is of more than 1,000 copies, this is a guideline basically which has been adopted by NACO. In other countries, they have other cutoff values. I'm not mentioning those, but for us, it is more than 1,000 copies per ml after 6 months of initiation of ART. That is the first 6 months of after the first 6 months of ART with 95% and more adherence, only then we will call it a virological failure. That is, a patient has taken his or her medicine for more than 6 months. He has consumed the medicine with good adherence, and after that, even after that, he has a high viral load. So this will be tagged as virological failure. What is immunological failure? A CD4 count at 250 following clinical failure, or a persistent CD4 cell count below 100. So a clinical failure is the patient is showing signs of fever, diarrhea, and other stage 3 or 4 illnesses. Along with that, patient is having 250 CD4 count. And a persistent CD4 count less than 100 is also a marker of immunological failure. Now, what do we call the clinical failure? We know that we have a WHO clinical classification, that is stage 1 to 4. Any patient who is having new or recurrent stage 4 illnesses will be classified as clinical failure. But all these have to happen after minimum 6 months on ART. Now, what is a viral load testing? Viral load testing, we know that is done regularly from our ART centers. Samples are sent to the referral laboratories. Now, viral load measures the amount of the virus that is circulating in our blood, and this gives us a hint about the prognosis of the disease. Now, what is PLHIV on first line and PLHIV of second line? These two cases have a different timing for viral load. Like a patient who is on first line will be undergoing his viral load at 6 months of ART, and thereafter it will be once annually only. But patients who are on second line or third line, they have to be tested for viral load every 6 monthly. Now, for patients, all PLHIV transitioned at 6 months, 12 months, and then annually on the first line, and every 6 months for patient on second and third line. Now, there is something, a substitution is there in a bracket. Basically, whenever we are switching, we know that we are changing a drug from a first to second or a second to third line. That is called switch, where there is a basic change of at least two class of drugs. But when we do go for substitutions, suppose my patient was on TLD and he or she had a marginally raised creatinine and he was found to be having features of CKD, then ideally we change the regimen from tenofovir to a renal-friendly drug, that is abacavir. For changing to abacavir, we are basically changing the regimen, if I speak in short-term languages, that is TLD to ALD. Now, this is a single drug substitution. As we can see, TLD to ALD means the L and D remains constant. We are just changing T to A. But what happens is, if I do not know the virologic status at this point of changeover, I might be changing a regimen in the face of a failure. So what happens is, if I change from T to A in the face of failure, abacavir will be the only existing effective drug, maybe the only existing effective drug, whereas the lamivudine and the dolutegravir might already have had failure. So the single drug which has been changed, which has been untimely changed without looking into the viral load, often fails very early. And to avoid this, whenever we have any substitution for any cause, whatever clinical cause, toxicity, whatever be it, usually after the first 6 months of ART, any substitution should be accompanied by a viral load done at the same time of substitution. Now, coming to the pregnant HIV positive women, we all know by now that between the 8th to 9th month of the pregnancy, that is between 32 to 36 weeks, we have to do a viral load. And this is basically to give protection to the child, and also deciding the prophylaxis for the child after his or her birth. Now, the chronology and the identifying treatment failure, how like when a patient is undergoing failure, that the ART is not effectively working against the virus, is not able to suppress the virus, what are the sequence of events that follow? This is a very old chart, and whatever beautiful chart. We have seen this from a long time. Now, the red line is the viral load. As we can see from the chart, in the x-axis, the viral load starts rising very early from the onset of treatment failure. It steeply rises over time. Comparatively, the CD4, that is the blue line, and the clinical status, which is the black line, they remain stagnant for quite some time till the viral load is higher. So, the CD4 does not go down immediately, neither do the clinical symptoms or the OIs crop up immediately. These are the things that crop up after a period of time. So, what is the best and the earliest measure to detect treatment failure? It is the virologic count. So, why do we need to do the viral load earliest? Because if I keep my patient on the failing drug for a long time, there is accumulation of drug resistance, mutations, and the drugs are lost. So if my patient is failing on ZLN for a long time, but I have not changed the drug, I have kept him or her on ZLN. What happens is the TAMs, that is the mutations, accumulate, and all the NRTIs are lost. Similarly, if I could go for a changeover very early, I could have prevented the accumulation of the resistance mutations. Okay, so viral load measurement is very important, and at the same time, the adherence issues is also very important. I'll come into the discussion. So, as per the new comprehensive guidance sent by NACO for the viral load testing algorithm, we have the viral load count. Viral load is tested every year, once in a year for all first line, once in 6 months for newly initiated and second and third line. Now, once the viral load has been done, there are two types of reports that we need to categorize. One is the continue the that the viral load is less than 1,000 copies, and we continue the patient on the same line of treatment. If the viral load is more than 1,000 copies, first and foremost, we have to see the adherence of the patient. Because if the patient has not taken the pills properly, we cannot expect an outcome. So, first and foremost is to look into the adherence of the patient. If adherence was less than 95%, then we have to go for the enhanced adherence counseling. First, we do the ESC1. ESC1, we see that for the first 3 months, we go on counseling the patient, we talk to him, visit with him. And if we find that the adherence was not good, then we will not do the viral load repeat. We will go into ESC2. Okay. So, but this ESC2 has to be supervised by the physicians at the ART center. So, what we need to do is basically ESC1 and ESC2 are nothing but counseling sessions, that is enhanced adherence counseling sessions every failure patient should undergo. And what is meant by enhanced adherence counseling, I will be showing in the following slides. I have to look into the factors which are hindering the proper intake of ART, other side effects, any issues with time, any issues with other concomitant drugs. These all have to be seen. Now, after ESC2, that is the second quarter of the counseling, we again do the viral load, and irrespective of the adherence. And now, if the viral load is less than 1,000, the patient is encouraged to take the same ART with the same good adherence. And if the viral load is more than 1,000, we go for a SASEP referral. First, we go for a ESASEP referral, and if needed, the SASEP panel will ask for the patient to attend the online or the physical meeting. Now, what happens if the last 3 months of ART adherence was more than 95? Then we test after the ESC1, and if we test for the if we test for viral load after ESC1, and if the viral load is less than 1,000, continue the same treatment. If the viral load is more than 1,000, we refer the patient to SASEP. Why we refer the patient to SASEP after ESC1? Because as per the ART counselor assessment, the patient has taken the pills properly. But there is a hidden story to this. All the EACs done at the ART centers, they mostly show a 95% or 100% adherence. But when these cases are looked into a case-to-case basis, when the referrals are seen by the COE, we find often that the adherence which was mentioned as 95 or 100% is not so. Patient has missed his pills. He declares that he went out of station, or he was sick, or he has some anxiety or some other issues which like barred him from taking the medicines. So assessing the adherence is very important. Just by writing down 95 or 100 is not enough. And this is a request from the SASEP that the adherence, if not assessed by the home center, it is very difficult for SASEP to function. Now, the barriers of poor adherence should be identified and addressed by the ESC counselor under the supervision of the SMO of the ART center. And the Issues like the clinical conditions, concomitant medications, these have to be looked by the physician. Counselors can ask about the timing, about the alarms to be kept, what are the issues, but the medical issues, the drug interactions, any toxicity, these have to be looked into by the physicians. We often come across cases where the patients are having vomiting with abacavir. Patient cannot just adjust to abacavir and then he stops it by himself. There are issues like severe insomnia by dolutegravir. There are issues like uh, nausea, vomiting, a pain abdomen. Like these things need to be looked into. So previously with efavirenz, we had those nightmares and the dizziness, CNS symptoms. So these are issues which even though the patient wants to take the medicine, he or she is unable to take it. So we just can't blame the patient. We also have to look into what led him to the poor adherence. Now, PLHIV who are going into the EAC2, that is the second quarter of the adherence counseling, has to be rigorous. That has to be followed by the ART counselor through phone calls, and the help of the CSC need to be taken. Home visits may be needed, and SASAP is expected to look into and understand the reasons for poor adherence and the reasons for other clinical unsuppressed viral load, and avoid unnecessary switch to other regimens. So this is also very important because often of a patient who is on first line, we mentioned that the adherence is 95 and 100%, and SASIP promptly switches the first line to second line. SASIP did not look deeply into the adherence. So there is a gap. The first line patient was shifted to second line, and because the patient is a non-adherent type of patient, he has not understood the importance of good adherence. So the second line is switched to third line in a very short period of time. But there are cases where we have seen after the drug sensitivity test that a third line patient is still sensitive to TLD or ZLN because he never took his drug on time. He never took his drug properly. So the first line is there, it's active. The second line is active. The class of all the drugs are susceptible. They are still working. So what has been what was the gap here? Because SASIP also should understand that we should avoid these very fast and rapid switchovers. We have to look into the case properly. SASIP also, before their meetings, they can call up the patients, they can talk to them once or twice over telephone, then they can call the patients by telephonic electro, that is a conference calls, or they can ask the patient to come physically. Adherence assessment is very important before we can really say that this patient is failing, because otherwise we will be going into these unnecessary switches. Now, this is a step-up adherence counseling form, Annexure 6. By now, we all know this, and this just documents the sessions of the counseling that the counselors are doing. Here, we have to name the counselor who, preferably one counselor has to follow up a patient for 3 successive sessions. The sessions need to be done every month. If the patient is not available, he'll be going out of station, he is busy with his work, he cannot come every month, then we can also take the sessions every 2 weeks. Now, the identifying factors are the barriers need to be understood. The interventions which are advised by the counselor need to be documented. Now, this is now mandatory to include the step-up adherence counseling form along with the failure referrals, so that the COE or the ART plus, whoever is seeing the referral, understands what were the barriers and what were the interventions that were done to relieve the patient from these barriers. Now, Annexures 5, as we know, it's a line list of PLHIV. Now, when the patient is failing, we, along with the name, age, and sex, we write the viral load count, we write the adherence that was at the baseline, and then the 3 sessions of step-up counseling for ESC1. At end of every session counseling, what was the adherence, and then the data of the repeat PVL, the outcome of repeat PVL, the SASIP referral, SASIP decision, and the second line or third line initiation. This is the unsuppressed viral load charter. Now, the factors to be assessed before confirming treatment failure. First and foremost, as I said, is treatment adherence. Without good adherence, we cannot expect a patient to have a suppressed viral load. And the reasons for non-adherence need to be explored very well. There are family issues of depression, stigma. There are issues related to workplace, some workplace problem, financial issues, issues related to a patient not really aware of the side effect, long-term effect of not taking his ART. So this is very important to assess whether a patient has really understood the importance of ART. Now, the drug-drug interactions, this has to be seen by the physician. Like a patient is having calcium along with the dolutegravir, or he's taking iron with the dolutegravir. Suppose a patient is taking the PPIs, the proton pump inhibitor, or the H2 blockers with along with the PIs. So these drug interactions need to be looked into whenever a patient is coming for pill pickup. We will always ask him, do you take any other medicines from any other outdoor? Because there are patients who are visiting multiple OPDs. And whenever they are visiting multiple OPDs, they are sometimes they show their green book, sometimes they do not. And sometimes the physicians at the orthopedic or the other OPDs do not look into the drug interactions when they are prescribing. So the person who will be seeing the drug interaction will be our ART physicians, because we very well know what are the drug interactions with our group of classes of drugs. Certain OIs and the occult malignancies may lead to the decline in the CD4 count. We know that the malignancies are related with chemotherapies, and chemotherapies, they decrease the WBC counts, and the WBC and the CD4 is a part of the WBC, so the CD4 counts also shows a drop. And OIs, because of the because our so that the first line barrier is our CD4 count WBCs, so it also goes down with the OIs. Now, these all need to be assessed when we are uh, about to classify a case as treatment failure. Now, the management of PLHIV, when VL report is available, we have to line list the patients with unsuppressed VL, and this line list should be generated on daily basis from the IMS. The line list has to be shared with the counselor. Counselor will call up the patient, and they will ask them to come to the ART centers. If the patient is unable to come back at that point of time, then we will start our ESC over telephone. Then intensive support is needed. 3 sessions, as I said, at minimum 2 weeks, or ideally 1 month at a 1 month gap. That is, ESC 1 will start, and then 3 months of ESC 1, we will assess the patient's barriers, the issues related to the poor adherence. Then it is preferred that the same counselor is taking the sessions, because if a patient has spoken about his stigma, about the family issues, about financial issues, these are things he would not love to talk the second time. So it's best that the same counselor talks to the patient for 3 successive sessions, because she will be knowing best, the counselor will be knowing best what were the issues in the first counseling and what are the changes or the improvements that has been done. If the counselors are changing, then there will be no continuity in the assessments. This session should be conducted when the patient visits the ART center to collect his or her medicines. These can also be done over telephone if it is not possible for patient to come to you at every visit. Counselors should use the Ready Reckoner and Step Up counseling form to facilitate the process. As I showed, the form has to be filled up. Now, in case the PLHIV is not able to come for the sessions and is on MMD, that is a multi-month drug, so these sessions can also be taken telephonically. We can always talk to the patient, tell him about the pros and cons of not taking the ART, tell him how to deal with the small minor ailments, and the timing, however, to be adapted to his comfort. So these are the issues we can also talk about over the telephone. And whenever we are counseling a patient, ideally a spouse or partner should be like tested, and the children should also be tested. Repeat viral load testing along with the other lab investigations must be done once treatment adherence is more than 95%. So after ESC 1, we find that the adherence is good, then we will go for the repeat viral load test. If adherence is not good, even after the first 3 months of ESC, we will move into ESC 2. What is ESC 2? Is the second quarter of adherence counseling. The second quarter of adherence counseling should always be assisted by the physicians. Now, the second quarter is very important because we know that the patient has already failed the first quarter of counseling. So he is moving into the second quarter. So all the issues, all the drug interactions, the family, financial, everything has to be spoken with the patient. Like, it is very important that he understands why like he is being questioned, and we will always refrain from like blaming the patient. We will refrain from very direct questions. Rather than asking him why don't you take your pills, it's better to ask him what is your job, what are your working hours, when do you leave home, when do you take your medicine, do you need to stay out for night duties, on the days when you are having a night duty, when do you take your medicine, is it very embarrassing to take your ART in front of other colleagues and friends. So how to tackle with these situations, how to take the medicines in in a separate box so that it is not identifiable. So very good counseling can always maintain a patient on the previous line of treatment. All efforts should be made to get the appropriate baseline laboratory investigations done. So when a patient is undergoing the ESC 1, ideally at that time, all the baseline tests should be done so that when the patient is attending SASEP or when we are sending the e-SASEP after RPVL, the baseline tests are all ready. And the recommendation for change is given by SASEP, and it should be started as soon as possible. Now, whenever we receive, the ART centers receive a high PVL report, that high PVL report should be like the second, after ESC 1, the referral should be sent to SASEP within 2 days, and SASEP will try to give an answer within a week. Now we know that there is a SASEP at COE and PCOE, and SASEP is now also held at the ART Plus centers. Now there are program directors and the deputy program directors, ART experts, JDCST, RC from the SACS, and the pediatrician from PCOE. SASEP at the ART Plus centers are held by the nodal officer, one expert from the ART, the SACS representative, the DAPCO DPM representative, pediatrician, SMO, MO from the ART center. Now, when should a PLHIV be referred to SASEP? Suspected ARV treatment failure, ARV adverse effects, drug-related complications, management of severe OI. Patients from the private sector who have received a separate other regimen. Often there are patients who come from a private sector with a first-line regimen of darunavir. So when they turn up at the RT center for registration, the physician is confused, like what to continue. So better you refer this case to SASEP and you enroll the patient, but you always send a SASEP referral to decide. To mechanism and modalities of SASEP, we have 2-3 types of SASEP nowadays. We know that e-SASEP is when we are sending a SASEP email, that is the e-SASEP. 50% of the referrals are replied by electronically, that is the e-SASEP replies are also sent. This is an e-SASEP. Tele-SASEP is when the patients are selected for an interview, and the telemedicine a meeting is arranged. This is a virtual meeting, virtual connection with our patients. That is the tele-SASEP. It's beneficial because the patients do not have to come to the COE or the ART Plus. They can go to their home centers, and the home center physician, SMO and MO, is there to help with the case. Now, treatment regimens. We know that we have this first line, second line, and the third line ARTs. First line, often we confuse like, is darunavir first line or is ATVR first line? No, we should never try to identify first, second, or third line from the class of drug. The thumb rule is a first line to second line and a second line to third line should always be accompanied by a high viral load. So a first line patient is the initial regimen given, that may be a PI, that may be darunavir, ritonavir, if the patient has received the first ART from outside. Second line is a patient has failed first line. We have documented at least 2 high viral loads. Then we shift a patient from first line to second line. And the third line is when the patient who is on second line for more than at least 6 months and is showing recurrent failure by 2 or more than 2 high viral loads, then this patient will be assessed by SASIP, and then sequentially the third line group of drugs will be given. So basically what we are doing is we are shifting the class of drug from one to the other. But there is no hard and fast rule that PI is second line or darunavir is third line. No. What the thumb rule is, the effective drug on first line has failed, so the patient is being given another class of drug, so this is second line. The second line group of drugs have failed, so there is another switch over to a new fresh group of ART class, that is the third line. Substitution and switch, as I've already said, substitution is a changeover when the change is done due to the ARV side effects, drug interactions, or program policy. Like when we shifted most of our patients from TLE to TLD. That was a classic example of substitution. Or when we changed our patients from ZLN due to phase out to TLD. That was also substitution as the patients were not failing. Now, what is switch? When we change ZLN to TLD, but in the face of failure, that is a switch. So, the same changeover, suppose it is ZLN to TLD. This ZLN to TLD can be due to 2 causes. One is program policy, because we had this order asking us to change over. But at that point of changeover, I did a viral load. The viral load showed a suppressed viral load. So the ZLN to TLD is a substitution. That is, my line of treatment remains the same. But another scenario is TLD to ZLN to TLD done. At the point of change, I did a viral load. After 2 weeks, I find that the viral load is high. So this will not be categorized as a substitution, but it will be a switch because it was in the phase of failure. So after any substitution after 6 months should be preceded by viral load testing. As I said, this helps to understand whether a single drug substitution is enough or whether the patient must be checked for treatment failure. Often we have our patients where the only single drug is being changed. Suppose a patient is having insomnia for quite several months on dolutegravir. So after 1 year, we had to change it to ATVR. So this TL-ATVR was done, but since the patient is already on TLD for more than a year, I need to do a viral load at that junction of time because I do not know whether the patient is already having resistant mutations with TL or not. So if the patient is having resistant mutations to TL and I change from TLD to TL-ATVR, the only effective drug is ATVR. And a single drug, as we know, will not be able to take the burden of ART suppression. And ATVR will be also lost in no time. Now, the expected resistance mutations, this is a difficult chart. Mutations are interesting as a subject, but it is difficult to remember. The classical mutations I will be talking about. As we see here, AZT, that is zidovudine, stavudine, lamivudine, the basic, these 3 NRTIs have M184 and then successive NAMs. That is a nucleic acid mutations. Okay. So what here we see is the M184 is classically associated with lamivudine. K65R is classically associated with tenofovir. Abacavir shows a resistance with both K65 and L74F, more with L74F. AZT has the TAMS, that is the trinucleotide mutations. And then we have AZT also associated with Q151, T69. Tenofovir, abacavir, and or tenofovir alone, as I said, K65R Dolutegravir we see here, there is a long list of mutations. A long list of mutation implies that this drug has a high genetic barrier. So, if you compare it with lamivudine, only M184 is enough to deactivate the drug. But to deactivate dolutegravir, we need 1, 2, 3, 4, 5, 6 mutations minimum. So, in other words, dolutegravir is not easily, it does not easily develop resistance. It takes a long time and a number of mutations to develop dolutegravir resistance. Whereas for 3TC, only one mutation at M184V amino acid, we have the resistance. So the take home word is 3TC should never be given alone because it takes only a little time to acquire 3TC resistance. Similarly, the PIs, they have a number of mutations, especially lopinavir, ritonavir. We can see at least 6 to 7 mutations that are needed for LPVR resistance. Darunavir also has a high genetic barrier. A good number of mutations are needed for resistance to darunavir-ritonavir combination. So, in other words, the drugs which have 1:1 ratio of mutation, that is, only one mutation can deactivate my drug, they should never be used alone. They should be used with caution, and they are the ones which are very easily deactivated, or they lose their potency. Comparatively, DTG and the PIs, the lower ones, they need a mutation at several points of our amino acid sequences, thereby they are not easily mutated. Basically the resistance patterns, they take quite a number of like few years to develop, and it's not so easy to overrule the drug. Now, second line ART regimens for PLHIV failing on first line ART. If the patient is on TLD, or I will go for the short abbreviations, excuse me for that, because if the charts are quite crowded, it's easier to go for the short forms. So if I am starting with TLD, then the second line will be T will change to Z, or T will change to DTG. And if the DTG was there in the first line, ideally the second line should have a PI, that is ATVR. If I have to give DTG in second line after exposure to first line, we have to remember that the DTG dose will be double. And as per the new guidelines, we have to preserve the existing NRTI backbone. So if a patient is having anemia and the patient was on TLD as first line, the second line will be dolutegravir double dose, atazanavir, ritonavir with TL. So in other words, we can shuffle the drug like it will be TLD plus atazanavir, ritonavir and an extra dose of dolutegravir. If the first line was ZLD, then the second line will be Z2T. NRTI is changed. Lamivudine stays and DTG is replaced with PI, that is ATVR. Other options are first line if NNRTI based, then the second line will be DTG or PI. If the first line was PI based, then the second line will be DTG or third line PI, that is the superior PI. If the first line was in an RTI PI based ART with zidovudine, then we'll change to tenofovir as the NRTI. If the first line was tenofovir or abacavir, we will change to zidovudine as the second line. So T in the first line goes to Z in the second line. A in the first line goes to Z in the second line. Z in the first line goes to T in the second line. And if we cannot give any of the NRTIs, then it will be double dose of dolutegravir with ATVR. Now the failing first line is multiple NRTI exposed. That is, all the efavirenz and nevirapine is exposed, and also the patient is exposed to ATVR or any other PI. Second line will be, we will give one PI, one dolutegravir, and we will preserve the NRTI backbone. And if the patient was exposed to PI, that is ATVR or LPVR in the first line, we will move to a superior PI in the second line. As we can see here, DRVR, ritonavir, dolutegravir, it looks like the third line regimen, but it is basically second line regimen because patient was already exposed to PI. So second line becomes here the third line drugs. Any PLHIV co-infected with TB and on rifampicin-based treatment receives the double dose of dolutegravir 2 weeks after the treatment completion of TB, because we know that rifampicin is a cytochrome P450 inducer. It reduces the blood level AUC of the drugs. So we have to maintain double dose of dolutegravir for 2 weeks post completion of TB treatment. Hepatitis B patients will continue with TL even if the second line or third line, whatever the regimen, or other alternative is giving entecavir. Entecavir dose is 0.5 milligram for patients who are not exposed to 3TC, and it is 1 milligram for patients who are exposed to 3TC. For those with HIV 2 or 1 infection, pregnant women and toxicity to ATVR, use LPVR instead of ATVR. Now coming to third line ART regimens. Now again, I will be speaking in a short form because it's easier to understand. This is a crowded slide. First line on DTG, second line with a PI, third line we move to the superior PI, that is the DRVR, with the maintaining the existing NRTI backbone. The second row, follow the second row. It's a first line with an NRTI, second line with the PI, third line with the superior PI and NRTI backbone. Coming to the third row, it's first line with nevirapine efavirenz, second line with the dolutegravir, third line again with dolutegravir, but the dose doubles. If we can recall the page where I showed the drug resistance mutations, we saw that there were so many sites of amino acid mutations which were needed for dolutegravir, 1, 2, 3, 4, 5, 6. So we can understand that dolutegravir is not washed off so easily. It remains potent even after being mildly inactive. So what we are doing is, a subject who is exposed to dolutegravir in the second line can still be on dolutegravir, but the dose has to be higher or double. Then it is effective and the suppression, viral suppression is there. Now again, I'll go for the short forms. First line is the PI, second line is DTG, third line, if we want to retain DTG, it will be double dose with the existing NRTI and darunavir. First line, second row. First line is PI. Second line, if the patient had nevirapine or efavirenz, which is not now available, then the third line will be DRVR, BD and dolutegravir OD with an RTI backbone, because patient was never exposed to DTG. That is why the dolutegravir dose is once daily. The third row, failed first line on PI. Second line was darunavir, ritonavir with an NRTI. Third line will be, we will keep darunavir, ritonavir with DTG introduction. So as we can see, there are few drugs like DTG or darunavir, ritonavir, superboosted with ritonavir, where even if the drug a patient is failing on the drug, still 1 or 2 mutations do not inactivate the drug. So in the face of mild failure, we can keep darunavir and dolutegravir to continue as the next line of treatment. There are scenarios here. I again go for the short forms. It's easier to understand. It's otherwise too crowded. First line with DTG. Second line with it PI or with double dose DTG. Third line, double dose DTG with darunavir. If scenario 2 is first line with NNRTI backbone, second line with simple PI backbone, third line with superior PI backbone. Scenario 3 is first line with simple NNRTI backbone, second line with DTG backbone, third line with DTG double dose backbone with DRVR and existing NRTI. Scenario 4 is first line with simple PI, second line with DTG backbone, third line with DTG double dose with darunavir and existing NRTI. Scenario 5 is first line with simple PI, second line with NNRTI, third line with single dose DTG and DDRVR NRTI backbone. Scenario 6 is first line with simple PIs, second line with either NRTI supported with darunavir. Third line, we will retain DRVR with single dose DTG. So, in scenario 3, 4, and 6, there are very important two things to be noticed. DTG, if exposed, can still be kept with a double dose. DRV, that is the darunavir, if exposed, can still be kept without increasing but keeping the same dose. So these are the two very high genetic barrier drugs which can still be retained in the ART, that is the regimen, in spite of the failure. Now, National AIDS Clinical Expert Panel, as SASEP, we also have a National AIDS panel at the NACO level, and where the SASEP can always raise their queries, and this is the email ID. But the monitoring of the patients on second line ART, we know that every 6 months we need to monitor their viral loads, and if they are failing, they have to go through the enhanced adherence counseling. As I said, good adherence counseling is very important, and the poor adherence or the major OIs need to be assessed. Now, coming to the monitoring of patients on second and third line, we know that the basic tests are always done at baseline. LFTs are repeated at 3, 6, 12, and 18, 24 months. Renal functions tests are also usually, because most of our patients are on tenofovir, we do it at 3, 6, 12, 18, and 24 months. Lipid profile is done annually. Blood sugar is also done only annually. In the first 6 months, our viral load and CD4 is done, and thereafter annually for our first line patients and 6 months for our second line patients. Now, CD4 testing, as we know that it should be done every 6 months till the CD4 goes above 350, and then if it is above 350 and the patient is suppressed virologically, we need not do it regularly. But if the physician at the AT center, the treating doctor, feels so, he or she can always do it. In the face of a switch, we should always again do the CD4. The TB is the most common OI. And for TB, we know that rifampicin has a problem with dolutegravir because rifampicin is a cytochrome P450 inducer. It reduces the blood level of dolutegravir. So the dolutegravir drug has to be doubled. Now, the rifampicin also has a problem with PIs. The metabolism is reduced, the blood level of the PIs is reduced. So we had the scope of replacing rifampicin with rifabutin, but it is no longer available now. So no use talking about it. Often we have to replace rifampicin with levofloxacin or other fluoroquinolones, or what we can do is we can keep the patient on dolutegravir. Now, the second line or third line regimens containing PIs, rifabutin, we used to have it with orange-brown discoloration of the skin, tear and the saliva. So levofloxacin, as I said, has to be replaced with the rifampicin has to be replaced with levo. Now, the side effects of few of the drugs, I will not go line by line. I will be only talking about the major side effects. Tenofovir, as we know, it is responsible for bone demineralization. It is responsible for a Fanconi like renal proximal tubular reabsorption is hampered. So, tenofovir, whenever we are giving tenofovir, we should suspect a mild CKD. We should suspect bone remineralization, and we will always go for an urine routine test. Routine urine helps us to understand whether the albumin or that is being shed off by urine, or whether a patient is having normoglycemic glycosuria, that is the blood sugar is normal but the glucose is being shed off in the urine. These are the things which will like give us a clue whether the patient is having tenofovir toxicity. And we can give calcium supplements to adolescents who are on tenofovir so that it does not lead to bone demineralization and the growth is not hampered. DTG, there are lots of CNS side effects with DTG. We have documented some hepatotoxicity with DTG. There were neural tube defect. There were warnings which now we have overcome those panics and with DTG induced NT defects. So, but now it's stable. But if we should always give an informed consent to women in the reproductive age group. If they want, they can go for another drug, non-DTG. Commonly found side effects of DTG is weight gain, and then it is the insomnia or sometimes nightmares. Atazanavir, we know that it is responsible, all PIs are responsible for dyslipidemias. They are atazanavir is responsible for unconjugated hyperbilirubinemia. As we all know that it is a competitive inhibitor of the uridine diphosphate glucuronidase transferase 1A1 gene, and this uridine diphosphate gene or UDG gene, as we say, UDG is responsible for conjugating bilirubin. So atazanavir is always inhibiting this UDG gene, and thereby there is the unconjugated hyperbilirubinemia. Patients will come to us with complaining of jaundice, my eyes are yellow, my urine is yellow, but we will go for an LFT test and there will be only a rise in the unconjugated bilirubin. SGPT, SGOT, alkaline phosphatase are usually normal. So only task of the medical officer is to assure the patient that this is a side effect of your drug. You are not having any jaundice. That is very important. But sometimes patients are alarmed with their cosmetic changes of yellowish discoloration of the sclera. In those cases, we can refer these cases to SASEP or we can go for a changeover of ATVR. Now, coming to, we know that the H2 receptor antagonist and the PPI should not be co-administered. It can be given 12 hours apart. Now, coming to LPVR, dyslipidemia, the most common side effect of LPVR because of the high dose of ritonavir is the GI disturbances. Patients keep on complaining of multiple motions, cramps in the abdomen, a sense of distension. These are very, very common and mostly common in the first 6 weeks of LPVR. And we have to remember LPVR is also responsible for dyslipidemia, and sometimes a worsening of the liver condition is seen, not much documented. And then there's a lamivudine, we have very minimal side effects. Sometimes hypersensitivity is seen, rarely pancreatitis, but very rarely. Now coming to darunavir skin rash, because we have to remember darunavir is a sulfonamide has a sulfonamide moiety. So we have to keep those sulfur drug allergy issues when we are in our minds when we are prescribing darunavir. Then coming to hepatotoxicity, other hyperlipidemias, all PIs are responsible for hyperlipidemia. If we go through the individual cases, we will see that most of our PI patients are having given statins or some other cholesterol reducing drugs. And then going to management, whether we should be changing the PI drug depends on how much the jaundice. If the patient is having unconjugated hyperbilirubinemia, usually the up to 5 or it's acceptable. If it goes beyond 5, the total bilirubin, and the patient is complaining that see my eyes are yellow, you can always refer the case to SASEP. And sometimes we also see that the ALT or the AST is deranged, but that is not a very common finding. Usually with atazanavir, there is only isolated hyperbilirubinemia unconjugated, and the enzymes remain normal. Now, coming to the hepatic insufficiency, dose adjustment is recommended. We give atazanavir only for child pug A, not B and C. B and C, we cannot give these drugs. And we also have to look into issues like chronic hepatitis B and C, alcoholic liver disease, non-alcoholic steatotic hepatitis, and other chronic liver diseases. We have to see these issues when we are prescribing ATV for them. Now, child pug score, we always have these in our mobile calculators. Encephalopathy, ascites, albumin level, bilirubin level, total bilirubin modified, prothrombin PT, and the INR. These are the issues. What we need to remember is usually in child pug ABC classification that we may also have encephalopathy when where patient is having severe hepatic failure. And child pug A, B, and C are the three classifications. 5 to 6 point is the moderate minimum, moderate is B, and highest worsened liver condition is C. Most of the ARV drugs can be given in child pug A, few can be given in B, and for C, most of the ARV drugs are contraindicated. Now, dolutegravir, as we know that it is a very good drug which suppresses our virus very nicely within a very short period of time, but it also has a few in drug interactions which needs to be looked into. We will not prescribe polyvalent cationic supplements with our dolutegravir. Divalent, trivalent cations, they should not be prescribed along with dolutegravir. Why? Because they chelate dolutegravir. Okay. So the calcium and iron supplements can be co-administered only if taken with food. Best to avoid it along with dolutegravir. Give dolutegravir 2 hours before or 6 hours after calcium or iron. And then we also have the organic dolutegravir interaction with metformin, as we all know by now. Metformin dose should not exceed 1 gram per day along with DTG. Why? Because there is a toxic high level of metformin which accumulates in the cells, and this can lead to other side effects and hypoglycemia. So why we should avoid prescribing metformin more than 1 gram? Because organic cationic transporters are there at the cell membrane level. The same organic cation transporter is used by DTG and metformin for transit in and out of the cell. If the organic cationic transporters are used by dolutegravir, then the metformin cannot use it, and as a result, it accumulates in the cell. The metabolism or the degradation of metformin cannot take place. So it accumulates in the blood and in the cells, and there is a side effect of high dose of metformin, high accumulation of metformin. Now, all PIs, we know some drug interactions are there with astemizole, cisapride, fluticasone, indinavir, lovastatin. Rifampicin, as I said, decreases the concentration of boosted PIs. Should not be used concomitantly. We cannot use rifampicin and PI together. We have to change either rifampicin to levo or the PI to any other class of ARV. Atorva, increased concentration of atorva is possible because PIs always are prescribed with a booster dose of ritonavir. And ritonavir, as we know, is a cytochrome P450 inhibitor. Ritonavir is responsible for increasing the blood level of most of the drugs because it does not allow the hepatic metabolism of a drug. So the presence of ritonavir along with the PIs, why do we give ritonavir? If we think about it closely, when we prescribe PI with a boosted ritonavir, that ritonavir small dose helps the body to retain that PI for a long time. So the ritonavir does not allow the PI to be fast metabolized. Similarly, ritonavir also inhibits those drugs which are following the same hepatic metabolism. And atorvastatin is also, the blood level is increased. So we have seen, most of us, we have observed that for most of our patients, we usually give a 10 milligram dose and we do not increase the dose. Now that is atazanavir with H2 receptor antagonists, ideally it should be always given. It can be given at a gap of 12 hours. And the famotidine dose should not exceed more than 80 per day. And ideally, 12 hours gap is enough with a PI and in between a PI and a H2 blocker. Now, atazanavir with the PPIs, preferably not to be given. And because we know that atazanavir needs an acidic environment, and PPI is a long term, has a long AUC and a long T half, so they keep the acid suppressed and does not allow good absorption of atazanavir. There are a few other drugs also like buprenorphine, which increases the area under the curve. Now that's the end of my topic today. I hope I was under like I was it made things easier. The key points are viral load as the preferred approach for monitoring PLHIV on ART over immunological and the clinical monitoring. We know that as viral load is available in our program now, we can do it from all our center level. It's a basic approach for monitoring our PLHIVs, how they are doing. Early and correct identification of treatment failure is vital in preserving the second line options. So before tagging a patient as failure on first line, second line, we have to look into the other issues. Clinical and CD4 count monitoring essential for HIV to PLHIV. Importance of adherence. That is, I'm repeating this again and again because uh, if the patient is on drugs and he is taking the drugs timely with good adherence, there are very likely chances that we can preserve the same class of drug. Second and the third line ART regimens need to be initiated after SASEP review. So a first line failure will be referred to the SASEP preferably within 2 days of receiving the high PVL report. And SASEP, as we said, that we revert back to the ART center with our reply within 7 days of receiving the referral. And that is the end of my topic. And thank you for patient listening.
Thank you, ma'am, for this session. Participants are requested, if you have any question, please unmute your mic.
Yes.
Mic access has been given to all.
Yeah, if anyone has any query, they can always call us at our EPAN number. COESTM, we have an EPAN number, and coestm1gmail.com. We will always answer queries. So I think that's easier because few of us we listen to our RDLS later on when
Okay.
we are having a leisure time. Okay, thank you everyone, and
Thank you,
that's
ma'am.
the end of my session.
Can we conclude the session now?
Yes.
Yes. Thank you.